Hello guys, Dr. Shubham here. In my channel, you can see a video on bradyarrhythmias. So today I thought to make a video on tachyarrhythmias, which are as important as bradyarrhythmias, and usually they get confused between which type of arrhythmia it is and how do we manage it. So I've tried to simplify it. We all know what is arrhythmia. Arrhythmia is nothing but the heart rate more than 100 beats per minute. And how do we classify it? Very important. So we have three classifications of arrhythmias. Either the anatomical classification. If, for example, this is a bundle of hairs, anything above bundle of hairs would be supraventricular, and anything below bundle of hairs would be ventricular, so as to say as a general. Second is from the QRS complex. If they are more than 120 millisecond or more than 3 small squares, we say it's a broad complex tachycardia. And then the third one we have is whether the patient is hemodynamically stable or unstable, right? What is the BP of the patient? What is the oxygen saturation of the patient? Because the management will differ. This will tell us whether we have to cardiovert the patient or not. Okay, so the most common mechanism of rhythmogenesis is the re-entrant. So what happens in this is that, for example, we say this is the heart. Okay, just imagine that this is your heart. Okay, so if this is the heart and we take this as the point of AVN, anything below it, this is a bundle of his. So uh, the rhythmogenic potential is coming from the SA node, that is a pacemaker. It will come down to the AV node and it will go down and will separate to the bundle of his. For example, if there's some accessory pathway over here, so what has happened? One pathway is here, one is going through here. So both of them, they will collide with each other and they will form a what? They will form a cycle over here. This cycle is a cycle of a re-entrant tachycardia, and they will have a slow conduction pathway and the fast conduction pathway. Most of the arrhythmias, whether it be a atrial flutter, AVNRT, so as to call it a TSVT, AVRT, all falls under the category of re-entrant. Second one, we has a automaticity that depends that a lot of signals are coming from the center point, and the second one is because of the ectopic. We have seen the ECGs where you can see the ectopics arising and then going. How will be the atrial ectopic? It would be narrow. And how would be a ventricular ectopic? It would be wide. Okay, and then we have a early after depolarization and a late after depolarization. So this is a cardiac cycle where we have the 1, 2, 3, and 4. What is going to happen in stage 1? In stage 1, we are going to find the opening of the funny sodium channels. So what do we give here? Here we give ranolazine. Then we have the second, where there's an opening of calcium channel. Then we have the 3, where there's an opening of a long-lasting calcium channel. And 4, where we have the opening of potassium channels and closing of calcium channels. So this area of 1 and 2 is known as a pacemaker potential, right? So here we have the early and after depolarization. Early after depolarization is helpful in the Torsades day pointers, and delayed after depolarization will be seen in the digoxin, right? Uh, Now, what is the approach? Yes, we will study the approach, but before that, I want to know that how the patient can present to you. So a patient can present to you with a palpitation. It would be episodic and it would be triggered by some event, by like walking. They will have a chest pain. They will have shortness of breath. They can have signs of heart failure, and usually the patient comes the first symptoms with the signs of heart failure, and with the atrial flutter with the rapid rate of more than 250, patient can even come with synchrony. So narrow complex tachycardia can be regular or irregular. So it's very simple to see. If the patient have a narrow complex tachycardia, okay. So what next? So what next we need to know, that we will see. So if the patient, so just look at my hand and we'll see. So this is our ventricle. This is our ventricle, and this is our atrium. Okay. So anything I'm saying, when is the narrow complex tachycardia occurring? When there is a problem in the atria. Okay. So when there's a problem in the atria, when there's a problem in the atria, we are saying that narrow complex tachycardia is occurring. Okay. So what are the causes of irregular narrow complex tachycardia? So it would be atrial fibrillation, which will have the absence of P waves, atrial flutter with variable AV blocks, and a multifocal atrial tachycardia where the P wave morphology, there will be more than three types of P wave morphology in a single lead. And regular, rest all are the regular ones. Okay. Yeah. So what are the causes of sinus tachycardia? Most common is physiological. Okay, in the young people, in the elderly, in the pregnant state, in the thyrotoxicosis, in a high cardiac output state, anemia, beriberi, pulmonary embolism, heart failure, drugs such as which calcium channel blocker, obviously they're going to bradycardia. Which calcium channel blocker is going to cause tachycardia? That is a dihydropyrimidine calcium channel blocker such as amlodipine that causes reflex tachycardia, and other sympatomimetic drugs such as salbutamol, adrenaline, noradrenaline. They all will cause sinus tachycardia. So what is the approach to the narrow complex tachycardia? So we have said that whether it is regular or irregular. So if it is regular, what you'll do if it is irregular? If it is irregular, look for the P waves. If the P waves are absent, it is straightforward a case of atrial fibrillation. If there are flutter waves, it is an atrial flutter with variable AV block. If there are three different P wave morphology, it is multifocal atrial tachycardia. Okay. Now, if you can easily visualize the P waves, look at the atria versus ventricular rate. If you cannot see the P wave, it is AVNRT, AVRT, or junctional tachycardia. Okay, a lot is written, but I'll simplify it in further slides. So there are different rates for the different tachycardia. Sinus tachycardia when it is 100 to 180. Atrial tachycardia 150 to 250. Atrial flutter is 250 to 350, and atrial fibrillation is 350 to 650. So how do we say that whether what kind of tachycardia is it? So we will give the patient adenosine. On giving the patient, three responses can occur. Tachycardia can terminate with AV nodal block. AV nodal can be slowed, or SA nodal slowing can be. If the tachycardia terminates with a P wave, it is definitely AVNRT or AVRT. If the tachycardia terminates with QRS complex, it is AVNRT, AVRT, or atrial tachycardia. If there is just a AV nodal flowing and there is a unmasking of the P waves, it is atrial flutter, and SA nodal flowing, the patient will get into sinus tachycardia. So this diagram tries to clear it out. So if it was a AVNRT tachycardia, we gave adenosine to the patient. So they terminated with a QRS and a sinus rhythm was obtained. In the second place, there was a atrial tachycardia. And what happened is, and there's a SA nodal flowing with now you can see a P wave. Third, there's a atrial flutter, and there's a this is a atrial flutter, and there's a AV nodal flowing, and now you can unmask the P wave. Okay. Now, P wave morphology, in which lead do you see a P wave? You see a P wave either in the lead 1, limb lead 1, AVL, and inferior leads. Usually it is biphasic in V1 and negative in AVR. So in the retrograde P wave, they will be negative in inferior leads, as you can see in AVNRT and AVRT. And abnormal P waves can be seen in a focal atrial tachycardia. So in this diagram, we can see that there's a short RP interval. In this, we can see that there's a short RP interval with pseudo R dash wave in V1 and pseudo S wave in inferior leads. Okay. So the next diagram. So what is a sinus tachycardia? Sinus tachycardia is a physiological appropriate sinus tachycardia, and then we have a pathological inappropriate tachycardia. So for the pathological inappropriate tachycardia, we have to give ivabradine 2.5 to 7.5 mg. BD is used these days. They are better than beta blockers. And the normal P wave morphology, except they are tall in lead 2, 3, and AVF, due to upward and leftward shift of the origin. Okay. Then we have a paroxysmal supraventricular tachycardia, that is the most important PSVT. So what is the treatment? You give a vagal maneuver unilateral. After that, you give IV adenosine. You give it rapidly 6 mg IV and followed by a NS bolus. And if it not relieved, you give 12 mg and then 18 mg. It is contraindicated in the patients of asthma, as it will cause a bronchoconstriction. If the patient is hemodynamically unstable, we will go for DC cardioversion. If the patient is hemodynamically stable, you will give verapamil IV, diltiazem. Diltiazem is preferred over beta blockers. And yeah, this is how it goes. So the next thing we see, what is the how do you give a wall salva? So you put the patient in a supine position. You raise the intrathoracic pressure by bearing down against the closed glottis for 10 to 30 seconds. Do not waste more than 30 seconds on this. And then you go for a carotid sinus massage. Always do it unilaterally and rule out a prior stroke or a MI before it by checking on a buoy. And just give only 5 to 10 seconds on it. If it is unsuccessful on one side, try on the other side. Okay. After this, we have adenosine. I've already told the dose. Give a 6 mg rush followed by 12 mg and maximum up to 18 mg. And where it cannot be given first degree AV block, SA nodal block, WPW syndrome, it causes a lot of bronchospasm, so avoid it. Second, we have said that diltiazem is very good. 0.25 mg per kg IV doses over 2 minutes, followed by 0.35 mg per kg over 2 minutes after 15 minutes, followed by an infusion of 5 to 10 mg per hour, increase up to 15 mg per hour. You can also give a metoprolol 2.5 to 5 mg IV bolus over 2 minutes. Very important is the contraindications. So beta blockers cannot be given in a heart failure, in the asthma and COPD. Diltiazem cannot be given in the heart failure, WPW and pre-excitation. So I was talking about the री-एंट्रेंट mechanism. एक तो था ही जो normal pathway था, उसके साथ एक fast pathway भी add हो गया, making it a re-entry circuit. So this is the electrical impulse. It is going through here with the fast conduction that is going and moving both of the sides to the bundle of his, and this is a slow conduction fast recovery pathway. This is normal. And now we'll see what will happen if there is a pathology in this. So what will happen if there is a pathology over here? So, for example, if there is a block in this fast conduction pathway, so this slow conduction pathway will get activated. So this slow conduction pathway will get activated, and now this will move. This will try to move over this side. Look at this diagram. This one. Look at this diagram here on to the right. This one diagram. So it will go and it will merge with the fast pathway, and here you can see that on arriving of the top of the fast pathway, it merges with the slow conduction pathway and form a circular movement, correct? So if there's a ectopic beat over here or a premature beat over here, that will activate the slow conduction pathway. Next, AVNRT is the most common type of PSVT. It is most commonly seen in females, and the patient might have a frog sign or a shirt flapping or a neck pounding sign. Why there's a diuresis? Because of the increased atrial natriuretic peptide release. So this is the typical AVNRT. You can see this is a fast conduction pathway. This is a slow conduction pathway. There must be some premature ectopic beats in the fast conduction pathway. So slow conduction pathway merged with the fast conduction pathway and form a re-entrant pathway. So we can see the conducted via slow accessory pathway. So there's a long PR interval. So how you are going to differentiate it, that there will be a long PR interval and P waves are usually negative or they are buried in the QRS. And here what will happen? Your fast pathway has got much activated. So you will have a long RP interval, right? So this is not very important. We'll go further. Yes, in this diagram, we can see that there are long PR intervals. So P is starting from here and going to here and ending over here. So with the long PR interval, you cannot see the P wave. They are just the T waves, and they are coming at a so how you will differentiate it? First of all, see at the QRS. It is a narrow complex QRS. Okay. Second, it is coming at a regular interval. So it is a regular narrow QRS complex. You cannot visualize a P wave, so it is definitely a typical AVNRT having the symptoms of PSVT. Now this is a atypical AVNRT where you can see that you can see the 2-3 AVF. What you can see the negative P waves in 2-3 AVF and a positive P wave in AVR with long RP interval. Okay. So what is the management of a AVNRT? So the treatment of choice is definitely a catheter ablation. You can also give a propafenone and flecainide to the patients. Now, what is a pre-excitation syndrome? I was talking about this diagram. So just we'll focus on this diagram, this one, which you can see here, this diagram. So what we can see here, there's a right atrium, left atrium, right ventricle, and the left ventricle. So there's a normal conduction pathway. So this is a sinus node, there's a AV node, and there's a conduction going through the bundle of his. But what has happened, there has been an accessory pathway in the left atrium, also known as bundle of Kent. So instead, what will happen, this left bundle what will happen to the right bundle, they will move through this pathway and they will form a circular motion. So this is known as a circular motion AVRT re-excitation complex, known as WPW syndrome. We'll see what we'll see in the ECG. Because of this, there will be a delta wave in the ascending QRS complex. We'll see how it looks. So let's see how it looks. See, now you can look in this diagram. You can look in this diagram that there is a kink in the ascending QRS complex. There is a kink in the ascending QRS complex. Here also you can see a and now there is a delta wave followed by a long QRS complex. So if you see a kink in the ascending pathway and a bizarre QRS, a little broad complex QRS, so it is WPW syndrome. So a short PR interval, definitely a short PR interval. You can see P is starting from here and ending here. So short PR interval with a delta wave and a prolonged QRS, you might have a STT changes without ischemia. So this is a WPW syndrome, very important. In the orthodromic, they will travel to the retrograde accessory pathway, and in this, they will travel through a retrograde over AV nodal pathway. So in this, there will be QRS duration. What you can see in the orthodromic AVRT, you will have a normal QRS duration, and you will not see a you will not see any of the delta wave, but you can see a retrograde P wave. But in the antidromic pathway, which is most commonly seen, you will see a broad complex with a delta wave. So I hope this is clear. There was a pathway that has been formed over here. So there will be a antidromic pathway, and a delta wave is because of this accessory pathway. And that has caused a shortening of the PR interval. So I think these are again the repeat of all that. So yeah, now you have to identify this. You have to identify this and you have to write it down in the comments that what does this ECG show. Okay, so you have to tell me what does this ECG show. What is happening in the ECG, what is happening to the QRS in the ECG, whether they are regular or irregular, and you have to write it down in the comment box. So how you will manage the patient of WPW, the therapy of choice is catheter ablation, or you can go for a pharmacological therapy. So this is a management. You give adenosine, then you give diltiazem. Never ever give digoxin to the patient. It is contraindicated. So management of AFib, this I have already discussed in detail in another video on my channel. You can see that. We'll move further. Just focus on this ECG, what you can appreciate. First, you can appreciate a narrow complex tachycardia, QRS tachycardia. Okay, there's a regular RR interval, fine. What you can see an inverted P wave in 2, 3, and AVF, and they are very deep seated. So usually such ECG is of a permanent junctional re-entrant tachycardia, which is seen along with cardiomyopathy patients. Look at this ECG, what you can see. So first thing you can see is that there is a narrow complex QRS complex. Yes, they are. Second, you can see that they are not coming at a regular interval. They are coming at an irregular interval. Yes, they are coming at irregular interval. Third, you can see the different morphologies of P waves. We have made an arrow over here. You can see the different morphologies of P wave. So what it is a multifocal atrial tachycardia. Now let's look at its details. So it's a multifocal atrial tachycardia, which can occur because of many reasons, and it is due to specific fiber orientation or because of a fibrosis post-surgery or post-ablation. This slide is very important. There's a focal atrial tachycardia, how you are going to deal with it. First, if the patient is hemodynamically unstable, you have to give a synchronized cardioversion. What is a synchronized cardioversion? When you give a cardioversion between two RR intervals, it is called a synchronized cardioversion. If the patient is hemodynamically stable, we can give IV beta blockers, and we can also give a IV amiodarone to the patients, okay, or IV ibutilide. IV adenosine can be given. Why IV adenosine is given? To differentiate between AVRT and AVNRT. We have seen that AVRT will terminate with adenosine, whereas AVNRT will just slow down. Okay. And always treat hypokalemia in the patients of focal atrial tachycardia. Look at this picture. Look at the ECG over here. Look at the ECG. What do you see? You can see the different P wave morphologies. What is a P wave morphology over here? What is a P wave morphology over here? So here it is a slam down. It is smash down. Here it is good. You can see a good P wave, and here you can see a slopey P wave. So it is a three different P wave morphologies in a single ECG, the multifocal atrial tachycardia. So, what are the causes? The most common cause is the pulmonary arterial hypertension due to advanced COPD. It can be a coronary artery disease, hypertension. Always, I've said treat a hypokalemia, and it can be because of a theophylline and venophylline. The treatment of choice here is IV Maxel to the patients, and you can give a oral diltiazem in the later stages. Have a look at the ECG. Look at the QRS. They are narrow. So it is a narrow complex tachycardia. Along with that, there's a regular RR interval. Yes, they are more so regular. But what you can see a lot of flutters. You can see a saw to third pattern. So this saw to third pattern is nothing but the atrial flutter. It can be typical, it can be reverse, it can be atypical. If it is typical, they will have because of a right atrial re-entry. And here it will be because of a re-entrant of a scarred tachycardia. So what you can see a lot of flutters and you can differentiate it out. So what is the management of atrial flutter? You give IV ibutilide, you give oral tofetilide. Atrial pacing can be done. Beta blocker of choice here is a short acting acimolol, and because the patient can have what do you say, a thrombus inside a right atrium, so always anticoagulate the patient. Very important over here is a Chadwa score, which we usually forget, but we all should know because this will help you tell uh, how to anticoagulate the patient and which drug to be given to the patient. So what is a Chadwa score? There's also a Hasbled score. So what is a Chadwa score? There's a congestive heart failure, hypertension, age more than 65, diabetes, history of stroke has been given 2 points, peripheral vascular disease, age more than 75 years, and category agent. Okay. Along with that, if the score is 0, there is no need to give an antithrombotic therapy. If the score is 1, give aspirin alone will do well, or you can give an anticoagulation with a warfarin or Novax. If the score is 2 or more than 2, you have to give the patient full anticoagulation with warfarin to maintain the INR of 2 to 3, and you can also give Novax. Now, what are the full indications of full anticoagulation? If the patient has a mechanical heart valve, there's a previous thromboembolism, rheumatic mitral stenosis, and hypertrophic cardiomyopathy. Okay. What are the newer oral anticoagulants? We have a dabigatran, we have a rivaroxaban, abiraterone, and edoxaban. This is such an important question. It is always asked in theory, whether it be MBBS, MD, DNB. Practicals may they'll ask you always what are the NOACs, NOACs, 2ACs. So always remember these. So dabigatran, it is an oral thrombin inhibitor, and the dose is 150 mg twice daily if the serum rate is more than 30, and reduce the dose to half if the serum rate is less than 30. रिवारोक्साबेन इज 20 mg वंस डेली. डेबिगेट्रम डी से याद रखो 2 बार लेना है इसको दिन में. रिवारोक्साबेन एक बार लेना है 20 mg वंस डेली. एबिक्साबेन यू हैव टू टेक 5 mg ट्वाइस डेली, एंड इडोक्साबेन इज 60 mg वंस डेली. ये ट्वाइस डेली दो हो गए, एबिक्साबेन हो गया और एक डेबिगेट्रम हो गया. रेस्ट ऑल आर वंस डेली, एंड दे आर आस्क्ड मल्टीपल टाइम्स. Now identify this phenomena. So what you can see a RBB form aberrancy with a normal orientation of a QRS factor. So this is basically a Ashman phenomenon. So I hope I should end this video over here, and in the next video we will talk about the wide complex tachycardia to make it easy for you, and it would be easy to split the video into. Thank you. So also I wanted to talk about the videos, the content, the type of content you want. You can message me over here. You can message me on Instagram, and whether you like more of a PPT form or you wanted a handwritten notes in the form. Also, might be in a month or two, I'll be launching handwritten Harrison notes. So do let me know the topics you want, if you wanted as a whole handwritten notes or the single topic handwritten notes. So do let me know and keep supporting. Thank you. Okay.